Okay, hi, welcome everybody. I am here to start us off. Thanks for joining us tonight for the prescribing activity as a pain treatment PCN pain rounds. I just want to start us off with the land acknowledgement. We want to acknowledge and honor the fact that those of us who are participating in the event across the province and other provinces share the traditional and current lands of the many First Nations, Métis, and Inuit peoples whose resilience and presence with us remind us of our treaty obligations and relationships. The province of Alberta includes territories in Treaties 4, 6, 7, 8, and 10, which include a diverse array of culturally distinct Indigenous peoples whose histories, languages, and cultures continue to enhance our communities and remind us of our ongoing relationships with each other, the land, and our own process of reconciliation. So we are going to just do a quick poll. Actually, we're going to do two. The first one is just to get an idea of who's here today by profession. So if you can just pick the one that applies to you. Awesome. So we have a physiotherapist presenting, but no physiotherapists. We have one anyway, Neil. Okay, awesome. Okay, welcome everybody. Okay, we'll just do the second poll now, and that is a location poll, just to see where everybody's come from. Okay, so mostly Calgary, a few from Central. Oh, and quite a few from outside Alberta. Awesome. Well, more from outside Alberta. Okay, great. Awesome. Okay, that's great. We have people from all over the place. That's awesome. Thank you all so much for joining us today. I'll just, all right. There is, if you check the chat box, you'll see that there is an attendance certificate in there. There's a link. It's already been posted there. So if you click on that, that is actually how they're going to issue our certificates of attendance. So if you can, right now, pop in there and just fill out the survey and put your name in there. And that way we can make sure that you will get your certificate. So if you can just take a second to do that, that would be awesome. And while you're doing that, I'll just draw your attention down where you have the chat function. There's another function, just the Q&A function. If you would like to post questions instead of putting in the chat box, if you could please put them in that Q&A area, that would be very helpful. All right. All right, so the learning objectives are here. I won't speak too much to those because Neil's gonna talk much more in his presentation. Just two quick disclosures. We receive in-kind support from the Alberta College of Family Physicians. They provide the infrastructure for the webinar, so the Zoom framework that we're using today, so we can put lots of people on here. And they also help us with publicity for our sessions. If this is your first time here, welcome. So the PCN chronic pain rounds are open to anybody, but we really do try and tailor them towards primary care teams, interdisciplinary teams. We are doing 6 per year, focusing on chronic pain and issues common to people with pain. We have been rotating the weekdays. They're currently from 5:30 to 6:30 and via Zoom. We have been playing around with the idea of potentially making them a bit longer, just because sometimes we don't have a ton of time for questions. If you have an opinion about that or anything else, please feel free to pop it into the chat box or put it into our evaluation form. We're going to put the link in for that in the chat box at the end as well. This is our planning committee. We have pharmacists, physicians, OT, a wide variety of professionals from every single PCN in the Calgary region. And here's just a quick overview of our upcoming sessions. So our next session will be Wednesday, March 24th. That will be at 5:30. And it's going to be A to Z's Better Sleep with Chronic Pain. And then our June session will be management of trauma in people with pain. And Kara Irwin, who's an awesome psychologist at the FCC in East Calgary, is going to do our presentation for that one. All right. So I'd like now to introduce Neil Pearson, who's our speaker for today. Neil's a physiotherapist, yoga therapist, and he's a clinical assistant professor at UBC in the physiotherapy and pain medicine subspecialty programs. He's also a consultant to the Division of Family Practice in BC, ICBC, Pain BC, and LifeMark clinics across Canada. I have no idea how he has time to do all of that, but wow. Neil is the founding chair of the Physiotherapy Pain Science Division in Canada. He's a recipient of the Canadian Pain Society's Excellence in Interprofessional Pain Award. He's the lead contributor of Pain BC's Pain Foundations and Gentle Movement Relaxation Series. He is faculty in 4 yoga therapist training programs, the author of the pain education ebook, Understand Pain, Live Well Again, and co-author editor of Yoga and Science in Pain Care, Treating the Person in Pain. Thank you so much for donating your time to talk to us tonight, Neil. I am really looking forward to it. And with that, I will hand it over to you.
Thanks so much. It's so great to have this opportunity to talk with everyone here. I'm just going to share my slides and then we'll get rolling. So we'll try to keep the questions together till the end. And so as you know, you can put if you have a question, you can put it in the chat or the Q&A area, I think. So we're going to be talking about this, prescribing activity. I'm speaking to you from the traditional land of the Syilx, which is the Okanagan Nation, and all the rest of that information is about where you are. And these are our learning objectives. We're going to focus on really on the first bit about how we can use activity and exercise in sort of a different way, how we can prescribe it in a different way than we usually are doing. In terms of the writing and exercise prescription, I'm not going to exactly tell you how to do that, but what I want to get us away from doing is treating exercise as only something to help a person be more flexible or stronger, which are typically what we tend to do when a person has pain. And there's so many other ways we can use exercise and movement. And these other 2 points here in terms of identifying healthcare providers, I think what we really want to do is not only look for providers within the healthcare system, but try to find people within our communities, because really when we're talking about pain, we're talking about a human condition, and a lot of people need support long after they finish with our care. And so in terms of the last part of giving you practical ways to stay active, you'll see how that fits in as we go along here. So my disclosures are that I do work in private practice, so I have my own business. I'm not going to talk to you about my own business, and also working as a consultant for other businesses, and we're not going to talk about that at all. So we always need to start with definitions. So definitions, prescribing. Really what I'm talking about here is us providing expert-guided care to the people we're seeing, and really not just expert care here, expert guided care, it's expert guided self-care, and to realize that this self-care bit is really, really important, and that when we are giving this to a person, we need to think of it a little bit more like a prescription, because sometimes when we give people activity to do or movement or exercise to do, a lot of times the person doesn't really see it as something that's vital to their care or an integral part of what they do. And so usually when we prescribe something, we give it to people, and then we definitely follow up the next time we see them, but we also make sure the person's doing it the right way. So if you give a person medication, you want to make sure they're using it the right dose, the right dosage, and you want to make sure that it's actually doing what you hoped it did. And so when we're providing movement or activity, we need to think of it more like that, so that the patient will as well. In terms of activity, just think of, we're going to be talking about here of really activity, movement, exercise, therapeutic activity, all those pieces, whether it's something that you're asking a person to do in their community or something that they would be doing in a clinic or in a gym, sort of fitting into all those pieces where we want to go with today. To go on in terms of talking about pain, pain's such a big topic. And so we're talking about prescribing activity to that relates to pain treatment. So the pain that we're talking about here is the pain that's not going away the way pain usually does, or We're not talking about the people who don't have complex problems, and we're not so much talking about people who have acute pain, although we'll talk about that a little bit as we're going on here. So just think of this is the people who come to us who have persisting pain and who can't quite figure out how to regain function or get back to their life. And in terms of treatments, um, once again, thinking about activity or movement as something that you could use to change pain itself. And you also could use it to try to impact how pain has actually impacted the person. So maybe the pain has made the person anxious, and you're thinking about using activity as something to address the person's anxiety. Or you could be thinking that you're also trying to show the person how to use movement or activity as a way to cope with what's going on. Maybe there's something that some issue that we're not really going to be able to change very much, but could you use activity to help a person to move with more ease or live with more ease? So hopefully that gives you a bit of a framework, but as you can see, it's a pretty broad framework from where we're starting here. I think you all understand the benefits of being active. You know, we can go right down to the idea of general health and well-being, um, but we also can get into more of the sort of system based perspectives on this. So we know that movement is generally hypoalgesic. So if you take people who don't have pain and get them to do movement, often what you'll find through research is that that a person's pain threshold will go up, and their pain tolerance will often go up as well when we get a person to be more active when they don't have pain. And we have some evidence that there are some people who have persisting pain who lose some of that. The hypoalgesic effect of activity or movement diminishes. And then we have some evidence that there are some people that it maintains itself in. And so we know we can even look down even more refined in this and look at things like macrophages, and that we know that when we are more inactive, that the macrophages in the body are more they tend to release more pro-inflammatory chemistry. And then when you're inactive, the macrophages produce more of the pro-inflammatory chemistry, and when you are more active, you tend to produce more of the anti-inflammatory chemistry. And so there's this idea that when we are able to move, we're actually able to open up this medicine cabinet. But there's so many nuances to this, especially that if we look at the research, at least in mice around macrophages, that if you take mice and you make them less active, the macrophages become more pro-inflammatory. And when you get them to return to their activity, it goes back the other way. So their macrophages become more anti-inflammatory, except for the first couple of weeks when you first get the rodents more active. As they become more active at first, you actually get more pro-inflammatory chemistry, which you see in the mice and the rats increase in pain behaviors, which is very similar to what we see in us, is that when we start to become more active again, at first when we become more active, it's almost like the sensitivity of the nervous system goes up. I mean, that's just one example, and we can go through the literature and see that when we are more active, there are changes that happen within the immune system, within the endocrine system, within the central nervous system, the autonomic nervous system, that a lot of these changes start to shift to the chemistry that has more to do with more activity. We get changes that shift towards chemistry that had to do with safety and rebuilding. Whereas that when we are more inactive, we tend to get more of the chemistry that sensitizes the nervous system or makes the nociceptive system more sensitive and able to send more signals through. So we can use movement to try to change the chemistry of the body. There's some evidence that shows that when we are more active in the right way, we can produce more endorphins, we can change production of serotonin, we can change production of dopamine, all of these things that might help actually change the pain itself. And so we can also use activity to try to desensitize. And I think this is one of the big things that we do is when we show people how to get more active, the nociceptive neurons and the nociceptive system that has become sensitized, as in central sensitization or sensitization is really a hallmark feature of persistent pain. And that when people start to become more active, you start to get the changes in the chemistry and the changes, really biopsychosocial changes that start to make the nociceptive system even less sensitive than it was before. We can also use activity to help to restore interoceptive awareness. This is one of the areas that I think a lot of people haven't paid a lot of attention to, and that a lot of times when people have persisting pain, there's a distortion of sense of the physical body, that the physical body can feel too big or too small or vague or hard to feel. And there's something about that distortion of sense of physical self that's I struggle with the words around this because we don't know, like, why is it that when people have a distortion of sense of self, and they have persistent pain, that the two almost have this positive feedback loop? Because we definitely know that there's a lot of people walking around in the world who are pretty disconnected from the sense of their physical body, yet they don't have pain. So when we see someone who has ongoing pain, has a distortion of the sense of their body or their interoceptive awareness, there's something about getting a person more in touch with their physical body, which movement definitely does, that actually helps to decrease pain. And we don't exactly know how to explain that, but that's another reason why movement can help. We definitely know that we need to look beyond just the body, right? Is that when we get people moving, we could prescribe movement to help a person feel more confident, or we could prescribe movement to help a person feel a greater sense of competence, the competence and confidence. From the yoga world, there are some, within yoga, if you've ever done that, there are some postures that are called the warrior postures. These are standing postures. And when we do them, we tend to feel strong and confident and competent. And so we could say, could we prescribe movement or activity to this person to help them to regain the sense of competence and confidence? And another thing we could use exercise for is try to find a way to help a person not feel so fragile. Because so many of us, when we have ongoing pain, it really feels like our body will break when we move in certain ways. And so, of course, there's that fear of re-injury. And so I'm sure you all know that we educate people about the fact is that it's not so dangerous, but sometimes we actually need to get people doing movements that gives them the actual physical experience that it's not so dangerous, to be able to shift that sense of fragility. We can also prescribe exercise in a way to help a person with social engagement. There's increasing evidence around the positive effect of social engagement on the autonomic nervous system, and therefore on stress and on pain. So it's another reason to prescribe activity or movement. And of course, we can do it to help people with stress management and restorative sleep. That generally when people are able to be more active during the day, we tend to sleep better at nighttime. It just has to be the right kind of movement. So when we think about activity as well, so we've got these benefits of it, but we also need to think of if we can sort of bring it down to 3 categories of why is it that we want this person to do activity? Do we want them, like the last one you see on the screen here is, are we giving the person the activity or movement so that they can challenge their capacity to stand as long as they do, or lift more, or walk more, or reach more? So are we using the activity as a way to challenge one's ability? Or maybe we might think about using or prescribing activity or movements to help a person to find more balance biopsychosocially, or to find more calm. Or maybe we're just doing it to give the person a chance to get a little bit of a break from the pain. And this is one of the things that I'd ask you to consider, that when you're prescribing movement to people, is that those people who are really stoic, and that person who it just seems like everything they're doing is just pushing, struggling, fighting. And of course, it makes some sense that it's hard to get better than when that's what you do all day. And we don't have good research around this, but we have clinically, a lot of people have said to us that they succeed best when they have their plan. Their treatment plan involves things that give them a break from the pain, or give them a little bit of respite from the pain. When they also do some things that work on calming things down, and when they do things to challenge their ability. People just don't do well when the activity is only focused on always trying to move forward, always trying to move forward. And hopefully you can understand, me as a physiotherapist, that's sort of my job in working with people with ongoing pain, is to help them to be able to stand longer, bend further, lift more. So what I've really found in working with people with ongoing pain is that if we can do these other pieces too, sometimes the exercise is to help them take a break, sometimes it's to help them find more calmness. And if you're not sure how you do that with exercise, don't worry, I'll get around to that. So when should we prescribe activity? I think what we want to do is start this really quite early on. Um, I I think one of the issues that we've had around activity and around self-management, self-care fully, is that we tend to, in the healthcare world, we tend to give those to people later. It's like we go through. If you think of the step care model, I was really happy to hear that the Veterans Affairs in Canada and the United States have both shifted their step care model. So their previous step model was step one is primary care, step two is secondary care, step three is tertiary care. But now what they've done is said step one is education and self-management, self-care. That's step one. So you do those things first, and then you get people into primary care, um, and or you do those two things at the same time, and then you move along. And the idea is that the movement, the self-care, the self-management starts at the beginning, goes all the way through our step care approach, and is going to continue on with the person at the end. And I think that we've unfortunately we've relegated it to, in the past we've relegated it to a role of that's what you do when the medical stuff hasn't worked. When we can't find what's wrong with you, that's what we're going to get you to do, is we'll start getting you being more active. So we want to try to do it quickly, and we're stuck in a bit of a place here because um, do you really need to really get into this with every single person you see in acute care? And the answer is probably no. But what we want to do is, as soon as we see the person not getting better like people normally get better, is how do we intervene then? So that transition from acute into persistent or chronic pain is, how do we intervene at that spot? And for those of you who've been clinicians for a while, you realize that um, you'll notice when someone's not following that normal trajectory of recovery. Uh, you know, normally, I mean, it's an interesting thing to think of, is that normally when we get hurt, we do what we can to make ourselves better. We do our own self-care at the beginning. And most of us actually get better doing that, but there's some of us that need to go see healthcare people. And when we go to see healthcare people, most times the traditional healthcare that we provide gets most people better. But there's this other group of people who aren't getting better like people normally get better, and we need to try to intervene quickly. I wish I could tell you that there's a lot of scales, but there are not a lot of questionnaires that guide us in this. Um, I'm just giving you one here. Dave Walton, who's a physiotherapy professor at University of Western Ontario, this is one of the scales that he's created. He created this scale, the Traumatic Injuries Distress Scale, specifically relation to people who have whiplash-associated disorder. And so the research has been done on that, not on chronic pain generally. But I offer it to you as an idea here because I found it really, really beneficial in helping, when I'm sort of wondering what's going on. It's only 12 questions. There's 3 factors in it. The 2 key ones have to do with uncontrollable pain and negative affect. But part of the other reason that I mentioned it to you is that when I've been working with the doctors of BC, we talked about this really quite expansive biopsychosocial perspective on how we could look at when people aren't getting better. And of course, there was this reaction of that may be more than someone could do in a primary care practice. It's too much time, too much work to do it. And so I then offered to the doctors this one to say, well, what about this scale? It's only 12 questions. And there was still, this sense of, that's still a bunch of things to ask. But if you look at the research around this, what's really amazing is that 2 factors became the important things. That when a person has the sense that their pain is not really controllable, and when the person has negative affect related to the pain, that those 2 things on their own are big predictors of whether this person is going to take longer to get better or delayed recovery. Now, as I mentioned, the research was done around whiplash-associated disorder, but in that area, they had a 85% prediction rate. And you can go to this website, and it's an open access scale, and it tells you how to score it. But it's something to consider, is that, when do we start providing activity in a more broad way, or when we start to think about activity as more than just getting a person moving again, but using it as a way to help a person to actually change the pain itself or to impact how the pain has changed them. A skill like this might help us to know when you need to start to do that sooner. So some other things that are really important, and I think a lot of you know these already, but in terms of when we're prescribing activity or exercise to somebody, it really needs to be meaningful. If it could be meaningful to us, but it really needs to be meaningful to the person we're working with as well. And really the second point here is that it's sort of in the answer to the question of what's the best exercise for somebody or the best activity. It's what the person will do. And so we need to be careful that we're prescribing something to a person that they will do. We've been doing a little bit of work with Veteran Affairs, and it's really fascinating how the yoga piece. There's so much research about the benefits of using aspects of yoga with people who have chronic pain and trauma. But of course, there are some people who one of the fellows said. There's actually a really fascinating little conversation because one of the fellows says, well, yoga is what young women in tight pants do. And one of the female veterans who was there basically echoed the same thing: is that that's not what they want to do. So these individuals were interested in things like Tai Chi or Qigong as other activity things. That seemed okay. So anyway, the point being is we need to find the right activity for the right person, something that the person will do and of course can do. If you prescribe the person that walking in a pool to help them with a leg fracture healing or pain in their neuropathic pain in their leg, but the person is afraid of water, that's just not what we want to end up putting that person in that position. And of course, they have to, whatever activity or exercise, need to align with the patient's goals. And this can become really important in the area of pain because the person in pain may be in the situation of thinking, well, the reason I'm here seeing you is because it hurts to move. And now you're telling me that I need to move. So my thought was that what I needed to do was actually get my body better and then I'd be able to move. Right? That's a logical sort of thought process. But when we prescribe activity to this person, the person may be thinking, well, that's not going to get me to my goal, because the person's senses or belief is that movement is because movement is painful, the pain means damage, so that's not actually going to help them get their body better. And so we need to make sure that uh, when we're providing activity or exercise to the person, even though we may understand why it would be the right thing to do, sometimes what we need to do is give that person the understanding to start with. Sometimes reassurance isn't enough. We need to actually give the person the logical explanation, and that's sometimes why we use pain education with people before they move. But of course, we know that education doesn't solve everything. There are some people that were way better off if we were to give them a movement practice that didn't leave them provoked when they were done, which takes a lot more work to figure that out. But if we can get the person to do a movement practice and they say, yeah, there's some pain when I do it, but the pain doesn't stay provoked long when I'm done, the person just now has had an experience that the movement um, didn't do what they thought, because the person is probably thinking that their expectation is probably movement is just going to leave me worse, it's going to flare me up. And if you give that person an experience that's inconsistent with what their expectation was or what their belief was, sometimes that's far more powerful for the person than just telling them why it would be a good idea. So this really fits into this point that I've been saying, the idea of making sure that we align our beliefs with the patient's beliefs. And sometimes this is why we want to give people pain education as a way towards helping them to engage in activity. But I really want to point out the idea is that sometimes what we want to do is get a person moving. And some of you won't have the time in your clinical work, but to find somebody who can help this individual in front of you start to move in a way that doesn't leave them provoked is often the evidence the person needs that movement, that moving with more ease is more possible. Because some people just have not had that experience at all. Just to give you sort of the out there example is, that a lot of people have learned that the only way to deal with the pain is to grit their teeth and just carry on and push through. And we know, of course, that that's the only way a person is approaching exercise. They're always going to flare up. So sometimes what we need to do is actually spend the time with the person. We ask them to be active, but then we're actually with them and watch them do it and get them to do it in a way that they don't just keep on pushing and pushing and flaring up the pain all the time. Another important factor is alliance. We can sometimes in physiotherapy world, people will say as well, if you don't have a good alliance with the person, you're not going to be able to get them to be more active. And to which, of course, what I would respond as maybe the process of prescribing and working with this person on an individualized activity program is exactly what you need to do to build alliance with this person, rather than having this idea that you can't do this without this. Maybe we should use the interaction as an alliance building opportunity. But it is important, right? And it comes back to the goals. The other point on this slide that I just want to bring up is something that you may not have heard of before. I stumbled on this about a year and a half ago, some research on a thing called autonomic synchrony. And this idea that our autonomic nervous system will start to sync up with the autonomic nervous system of people that we're around. And I got to say that I've been finding a little bit of on virtual care and virtual conversations is sometimes um, the stress or the anxiety of the person on the other end of the line. I can feel it actually starting to change my autonomic nervous system. But just to start with a simple, you can imagine if you go outside and you walk along the street beside somebody, your walking pace will start to sync up with theirs. And what the research is finding is that when you are working with somebody and there's an alliance between you and another person, is that there will be a syncing up of autonomic nervous system physiology, so that heart rate variability, the way we breathe, or so that our respiratory rates, even some brainwave activity and skin conductance in some research has shown to start to sync up between people. The reason I bring this up here is that sometimes when you're getting a person to be more active, you can get a person to, like in your clinic or while you're with them in a virtual setting, you can actually get them to be active. And while they're with you, they can do it and they can succeed. And there's a possibility that that person might come back to you. Say if you're seeing them one-on-one, the person may come back to you and say, when you're guiding me, I can do it, but when I'm on my own, I can't. And often we would think, well, that's got to be that they're just not doing it right anymore, and my instruction is what's helping. But it's possible that your calmness and the reassuring nature of you and your autonomic nervous system is having effect on them. Now, I throw that to you as a theory because we don't know that it can happen across virtual, and we don't have any outcome studies around this. But I think it's something to consider. And even to take a step even further, is that it's possible that this person in front of you may never find a way to actually regulate their own physiology by themselves. I think the majority of people in the world can with practice, but we have this term self-management and self-care, and it often ends up sounding like a solitary, isolated, lonely thing. And that we really actually want to think about is that maybe this individual sitting in front of us or standing in front of us or in the virtual care, maybe this person is the kind of person that needs to do this as part of a group. That maybe the processes of the group, whether it's autonomic synchrony or whether it's some other social engagement aspect, is actually allowing this person to succeed with the activity when they might not be able to do it on their own. We just have this idea, I think, that people can always do it on their own. We can always show them how to do it on their own and they'll always succeed. But maybe what's happened, this person in this life has set them up so they really need support of others to succeed with this. So when movement is painful, we need to be able to give people options. And so I just want to suggest to you some different options here. So the person in front of you is saying, yes, movement hurts. So how am I supposed to approach this? And I think what we want to do is tell people that there's different things we can do. So let's talk about these options or try these options and see how we get. So sometimes the person in front of us, we can get them to move around and we can find, here's the movements that make them feel worse. Here's the movements that don't really change the pain. And here's the movements that actually feel better. There are some individuals where we work with, even who have persistent pain, they will have some movements. They say, when I do these movements, it doesn't make the pain worse, or it actually makes me feel better. So that's an option, right, to start there. Yes, we want to challenge the things that the person can't do, but maybe the place to start with this person is movement that just feels good, because that's going to start to open up that medicine cabinet. It's going to start to affect the person's ability to feel more confident and competent about what they're doing. Another thing that we can do is, as I mentioned, and I think you all know about, is the idea of reassurance and pain education. Sometimes to help a person when it hurts to move, what we need to do is give the person the knowledge that the pain is not a direct indication of what's happening in the body. Get the person to understand that there's a big buffer when we have ongoing pain, that there's a bigger buffer now between when the pain gets worse and when damage would happen. And so giving that person that reassurance and teaching them about how to reconceptualize pain, really, as Lorimer Moseley and David Butler have really highlighted, really more than anybody in the world, but lots of the rest of us have been doing it, but those are the big names in the area. That can help, right, to give that knowledge first. We can also use imagery as another approach. So we can get people to imagine movements. So when a person says, even the smallest movements are making me worse, you might think, well, where do we start with this? Well, to get that person more active, maybe what we need to do is get the person to imagine movement first, to visualize it first. And often this piece that we find is that some people, when they imagine the movement, some people imagine the feeling of the movement, and other people imagine the sort of the visual experience, or what the visual would look like of that movement. And it seems that people, especially with a really sensitized nervous system, are better to start with the visual and then move into the more felt sense of this. And any of you who've done mirror therapy realize that the mirror therapy, or even virtual reality, is providing the visual to begin with. And so we can start with that visual imagery and then move into kinesthetic imagery, and then actually move into actual movement. And I know you'll get patients looking at you funny when you suggest this. And what we need to say is, athletes do this all the time. When an athlete's had an injury, before they can start to move their body, we will get them to imagine the movement, and it actually helps prepare them for the movement. So it's not like the imagery is going to make everything better, but it's a start. If we can get you to imagine moving without pain, and we get you to repeat that often, then we can move into getting you to move gently, a little bit at a time, and without provoking the pain at that time. I'm sure you all know that we can teach people mindfulness. Mindfulness, the idea here would be to help a person to be more present, to get out of that catastrophic thinking, away from the rumination about the past and the worry about what's going to happen in the future, and into the present moment. And when we can do that, which is often a very hard thing to do, but if we can keep a person mindful of the present moment while they're moving, often we can decrease the reactivity of the physiology when there are no nociceptive signals going through. And there's some good evidence, there's some good evidence that mindfulness meditation actually changes, that the pain relief from mindfulness meditation is actually a different mechanism from the pain relief from slow breathing, and a different mechanism from movement in itself, which is pretty fascinating, the idea that there are multiple mechanisms of pain relief within us. Other options, we can get people to listen to multiple alarms to know how hard to exercise or how hard to push. Think away from the pain area for a second to people who have rheumatoid arthritis. If someone has rheumatoid arthritis, we don't tell them to just use pain as their guide for how much to move. We ask them to use pain, heat, redness, and swelling. So we're actually asking them to use 4 different alarm systems. And so pain is an alarm system or a protective mechanism, but it's not the only one you can pay attention to. And sometimes when people are moving, it helps if they pay attention to their breath, their body tension, what's happening in their mind, and the pain, which I know is a lot to do, but we ask people to do with rheumatoid arthritis that pay attention to 4 things. And so there are some people who, if they listen to what's happening with their breath, what's happening to their body tension, what's happening with their mind, and what's happening with the pain while they move, that they're way more successful at finding that right amount of movement that doesn't provoke it or flare it up all the time. On the other hand, you could do a more simple thing, is you could use the idea of provoke recover, which we've borrowing from the concussion area. In the concussion area, we ask people within a few days after concussion to purposefully provoke the concussion symptoms. which if you've never had a concussion, imagine we're asking people to, on purpose, provoke dizziness, nausea, headache, and then once it's provoked, to stop and recover. And so when people are trying to use movement as a way to get better after or when they have pain, sometimes the only thing people pay attention to is the pain during the movement and don't pay attention to what happens afterwards. And there are some people who say, if I my trial to figure out how much I should exercise or how much activity to do is based on how long does it take to calm back down when I'm done. And of course, it'll be individual for people, but mostly you might start with saying, if the pain calms down within 20 or 10 or 20 minutes after you finish doing the activity, that might be the place where you start, and then people can play with it from there. But hopefully that would make some sense. And of course, the other idea is when movement's painful is to start low, like, say this is what the person's doing. Let's start way lower than that and then start to slowly progress from there. These techniques can work. But the idea is that there's a bunch of different options that we can use. And often when we're prescribing activity, we do one. We think of, okay, this is what everyone needs to do, rather than here's this person, how do we individualize the activity approach? Rather than just individualizing the activity, individualize the approach to the activity that we want this person to do. So one other thing I just want to mention, I can't help but mention with this, is that some of the people, some of the physiotherapists that I've been talking to have been saying that since they've been doing virtual care, and sometimes a combination of virtual and self-care, virtual care and one-to-one care, is that they're finding that some of the people are actually complying, or it seems that people are complying with their self-care or their activity program more than they did when they were coming into one-to-one. And this got me wondering, this once again, purely theory, is that when we provide virtual care to people, is there this implicit message that self-care, what you do, what I show you, the expert guided self-care that I'm showing you, is a absolutely vital part of what we're doing, or the only thing that we can do in this case if all we have is virtual care. And it'll be interesting to watch this as time goes on to see whether this is something that it will get researched, and whether we'll see that when we actually provide virtual care as part of what we do with people, whether that actually gets people to engage better. And so the idea with here is that maybe using virtual care when you're prescribing activity is one of the ways to actually increase the uptake or the engagement of the person with it. And just around virtual care, the last point in the slide just says to remember that just because the person is isolated from you doesn't mean that they have to feel isolated. We can feel isolated when we're in a crowd, and we can feel absolutely connected to other people when we're thousands of miles away from them. So we need to think about virtual care, I think, more in those terms. These options that I just gave you, if you want to see them in practice, then here's the website to go have a look at. So when the pandemic started through PAIN-BC, we created 37 gentle movement classes, all based on the kinds of approaches that we just talked about. And those, if you go have a look at those, they're all really gentle. And some of the feedback that we got from people was, I never even thought you could move that gently. It didn't even cross my mind that that gentle movement would be so advantageous. And so people were picking up this activity, using, learning these new approaches to activity and using this as the stepping stone. Often, I think the thing was happening is a person was, not very active and was trying to do this. And what these videos allowed the person to do is find that intermediate step of being able to move and learn a new approach to movement that wasn't going to crash them all the time. And I think that's about where I want to get to. There's a couple of things I just want to summarize before we open up to comments or other questions. Is that when you prescribe activity, to think of it more broadly than activity to get the person stronger, but to think of activity as, could you use the activity to affect the person biopsychosocially? Could you use activity to help the person re-engage with their social community? Could you give exercise that would help to lift depression? Could you give exercise or activity to help decrease anxiety? I mean, the answer to these questions is absolutely yes, you can, but we often don't think of prescribing activity for that, because we usually think of activity as, you're using the physical body, so this is for the bio. And what we really want to do is recognize is that we want to think of activity as very much as a biopsychosocial spiritual intervention rather than just a way to change a person's strength and flexibility. I hope you'll start prescribing activity in a different way earlier on. I hope you'll give people permission to try different options because there's not one size fits all for how to do it. And the other thing I hope you'll do is you'll reassess when the person comes back. If you're going to prescribe activity to somebody, you get them to do it, and use brief action planning so the person says back to you what you've asked them to done, and then ask them if they're confident, how confident they are to get it done. And then when that person comes back, when you've given them this, you've prescribed activity, when they come back the next time, it's like the first question out of your mouth should be, how did you do with the activity that I asked you to do? Rather than how's your pain, what you want to do is go over to how did you do with the activity, and check it out, because maybe the person hasn't been able to do it, maybe they forgot how to do it, maybe they've done it the wrong way, but we definitely need to follow up. If you're going to prescribe it, then think of it like this is a treatment. It's not just something to entertain the person or distract the person. You want to think of it more as how do you get specific goals? Is this to give the person a break from the pain? Is it just like going for a walk in the woods, give the person a break from the pain? Is this something that you're getting them to do to try to restore their ability to feel their body or calm their physiology? Or is this something you're getting them to do to challenge their function, to be able to lift more, bend more, all those sorts of things? And the last point is look for community partners. Find people in your community who you can suggest that their patients go to when they are finished with the healthcare system, or when the healthcare system is only seeing people intermittently, because the majority of people that we see are going to require ongoing care, reassurance, guidance with self-care after we're done with them, usually within the healthcare system. So I'm going to leave it at that. See if there's any questions.
Wonderful. Thank you. It's so nice to hear you speak. That flew by. When you said you were done, I thought we had ample time. So I can't believe it's 6:15. So thank you for your information, for your expertise, and just for engaging us tonight on this Tuesday evening that's coolish in Alberta. So yeah, we do have a few questions and just a few from our panelists. So I'd like to start us off with, you said some points here at the end and at the beginning. Really liked how you mentioned the idea of competence versus confidence. And so stemming from that, how can we increase the confidence of people we work with to begin moving? Let's say if they're fearful or they've not done activity in a while, it'd be nice to, look at, I know this is general, but your pearls of wisdom. So that's one question. And then you spoke about permission to give people to do varied activities, that follow-up and to keep going. Really loved that comment. So question and comment about the competence and confidence.
Right. So I think there's lots of different ways that we can help people feel more confident. I think one of the ways, one of the sort of the starting way is for us to feel confident that we can help this person to move with more ease. And one of the things that we struggle with as healthcare professionals, if we haven't seen it happen, or if reductionist views or very biomedical views around pain are really strongly embedded in us, that person who has, say, spinal stenosis, or the person who has this really ugly looking knee X-ray, and sometimes it's still embedded within us, is that we really don't see how this person could be able to move with more ease, and have that anatomical or pathological thing happening. And so part of it is that we as healthcare people really need to get to that point of recognizing that, I'm thinking like, how do you get there? Well, you get there through studying pain and actually working with people with pain for a long time. But to recognizing that pain is not a tissue health meter, and that tissue pathology is not sufficient for a person to have pain. These things just don't go together, but that's so embedded within us. So I think we need to study pain more. I think we need to listen to the experiences of people in pain more, because a lot of people who have have ongoing pain, the story and what's going on with them doesn't match up with how, if the person's succeeding is going to have a lot less pain than we would think based on what's happened to them. So we need to have that for ourselves. And then I think what we need to do is we need to have a language that's reassuring with the person, and a language that says that sometimes as simple as, we see lots of people with the thing that, this thing that you've got going on, whether it's a spinal stenosis, bulging disc, or we have a joint, to be able to say that we see people a lot of times with this, and the kinds of things that I'm going to get you to do. A lot of people say that they can move with more ease and live with more ease and have less pain when they're better. So just giving people that reassurance that we understand what's going on, and we've seen other people get better. That often is what we want to do. But also being able to recognize that some of the people who are in front of us, we need to tell them a lot more than that. There are some people who are not going to be able to get them to feel to have the confidence that it's okay to move without us telling them more about how this pain thing isn't what they think it is, and what it's telling them isn't what they think it is. And I guess the other pearl wisdom I would add is that recognize that some of the people, when you start to try to educate them about this, what we need to do is we need to watch the person in front of us, because sometimes that person in front of us is clearly showing us behaviors that they don't understand, or this is not making sense. And with that person, what I think we really need to do is stop and say, what can I do to help this person out? And it's not specific in terms of what we're talking about here, but as a physiotherapist, if I had that person who really wasn't ready to listen, or didn't think that that's what they needed to do, one of the things that I could do, because there's so many things within physiotherapy that I can do to someone to actually give them the experience that the pain is changeable. And it's one thing that we often don't think about. So I'm trained in manual therapy. If you had neck pain, and what I could do is actually sort of check how much you can move your neck, then do some manual therapy to your neck. And if you then at the end of that can move your neck with less pain and with more ease, then what I get to do is say, that's amazing, your pain changed. So the person has just had this experience that pain is changeable without changing their tissue, but that's not what the person thinks. The person thinks, I fix them. And what I need to do is give that person an experience that they can understand, is that I didn't fix the tissue, but their pain changed anyway. And if it can change doing this, let's look for the other stuff that can change it, right? So we need to realize that the sense of pain not being something that can be changed, that the sense that pain is immutable, is one of the things that really makes people lack confidence that they can get better, because the person may have never had this experience that pain is changeable. Anyway, I think I could probably go on with more pearls, but we'll leave it at that.
No, that's wonderful. I heard very clearly there's empathy, there's compassion, there's language, there's paying attention. So thank you so much. I know that helps reconfirm a lot of the things that can be applied not only to activity, but just to how we conduct and we work with people. So thank you. One of our panelists heard you mention some steps towards recommendations. I think you were referring to some guidelines at the beginning of your presentation. So was there a particular guideline that you were referring to that you can recall at the beginning of your presentation?
No,
Lana, do you want to pipe in if you want to, if you remember? Yeah, maybe.
Sorry, Christelle. Yeah, Neil, you were just saying something about you were really happy that they had sort of decided to add education in as kind of the first step, and I just wasn't sure who they were.
All right.
Perfect.
Yeah.
Thanks, Lana.
Yeah. So it's actually the Veteran Affairs Group in the United States and in Canada have come together and changed their stepped care approach. So we don't have any data that it's making things better, but it's the kind of thing that I think will, if we relegate self-care and activity to the last thing we get people to do, then people sort of see it as, yeah, it's not really going to work. But if we position it as, this is the stuff you need to start with, and you're going to be doing it long after we're done with you in the medical system, I think people are more likely to engage with it, but we need to wait for the research to see.
Awesome.
Yeah, thank you. You mentioned, and I think I might unfortunately get this name wrong, but the autonomic synchrony, is that correct?
Yes.
That section when you mentioned that was fascinating. So I'd like to peruse and learn more about that. So you spoke about the person in front of you may not be able to manage on their own and may need someone, this person may need some supports through working in a group. So we had a question posed, is the opposite true then too? If you have two activated patients, may they undermine each other potentially?
Yeah, and I'm guessing the person who's asking that has seen it, like pretty much all of us have. You know, especially you have a group and one person is wildly activated, and if the rest of the group is sort of not got a really decent self-regulation capacity, you can see the whole group sort of get wound up in that person's experience and their story. And of course, with autonomic synchrony, the big question is like, whose nervous system is going to sync with whose? Sorry, that's bad grammar. You get the idea, right? Is that I think you, once again, all of you have experienced a person coming in to see you, and your calmness has come into them and helped them calm down. But you've probably also experienced the person who's come in and their anxiety or their stress has just worked you up as well. You haven't been able to regulate in the face of this. And to me, it's really fascinating that we're actually researching this this experience that I think would have been put down mostly to purely to psychology, but people are saying no, this is the physiology of our body, and I think we need to recognize that the physiology of our body biases the nociceptive system, right? I don't think there's any problem with understanding that. Is right when our physiology is in a wound up state, when we can't regulate our breath, when we can't regulate our body tension, that these things really bias the nociceptive and any threat mechanism within us that would give us more pain.
Wonderful, thank you. And building on that, I think soon after that topic, you spoke about the buffer, and I think you referenced the two Australian physiotherapists. So what would be the difference between being in pain in that buffer zone versus grin and bear it situation from your experience?
Yeah, that's a great question. So, so when you move and the pain increases, when there's a sensitized nervous system, we believe that the alarm gets louder further away from where you damage it. So normally the alarm sits up close to where you damage the body, but when you have pain, because the nervous system is more sensitized, it's further away. And so when we're getting people to use that idea, we're asking them to go up to where they're feeling the alarm increasing. But when they're there, to ask, I mean, if you look at Mosley and Butler, one of the key things they get people to recognize is that the alarm is not telling them that they're actually damaging themselves, but also asking people to do this very cognitive approach of asking, how dangerous is this really? Right? Because the system is saying it's dangerous, but danger is actually not until up there, right? You're here, the system is saying it's more dangerous now, but the danger to the body is not up to here. And so when you get up there and the system says, hey, this is dangerous, and you ask, is this really dangerous? If you come up with, well, actually, no, it's not, then that should calm things down and you should be able to do more rather than the grit your teeth kind of thing. It's actually what we're doing is actually ignoring the alarms. So yeah, trying to make sure I say this in a precise way. So when we get to the spot where the pain starts to get worse, if we just carry on ignoring it, it's almost as if there's a mechanism within us that says, you don't listen so well, right? This alarm is supposed to be telling you to change your behavior, to slow down, to stop, but you're not listening. So what are we going to do? Well, what the alarm system is going to do is actually act as if you don't listen well. So it's going to crank itself up. And next time it's actually going to turn on even sooner than before. Whereas if you go up to that spot where the alarm starts to get louder, and if you can say, yes, yes, it feels like this isn't as dangerous as the system says, you sort of stay there and you work there. Now, when I'm working with people, I go further than Mosley and Butler, and I would say is you go to that spot and you ask, am I safe in terms of my body? And will I be okay later? And then what you also do when you're there is you do your very best to keep your breath calm and your body calm, and you pay some attention to the pain. This idea of these sort of listening to 4 alarms of, so you go to the spot where the pain's a little bit louder, instead of just pushing through, you sort of hang there for a sec. You keep your breath calm, you keep your body calm, you ask, am I safe? Will I be okay later? And you pay some attention to the pain. And you may say when you do that, oh, it's okay, I can carry on doing this and I'm all right. Or you might say, hey, I can even push harder and I'll be okay. Or you might do that and you might get to that spot and it might be that you can't keep your breath calm, you can't keep your body calm, you can't keep your mind calm. And the only way to do it is to ignore the pain. And if any of those things happen, then you say, all right, that's enough for right now.
Oh,
If
I
anybody's
liked
really,
that. Sorry, I thought you were done. I was like, oh, I liked that. Go on.
I was just going to say, if anyone's interested in a resource around that, there's a lot of things on PAIN-BC that I've done that we talk about that. But there is a free online resource that's a website that's called lifeisnow.ca. And if you go on there, there's the same thing called First 5 Steps Free. And it's a totally free thing that you can send patients to, or you can go have a look at. Step 1 gives some education. Step 2 is a breathing technique. Step 3 is a body tension calming technique. And step 4 is the movement guidelines that I just gave you of, am I safe? Will I be okay later? Can I calm my breath? Can I calm my body? Can I pay attention to the pain? It's all there in this free little thing that guides people through. Just to mention is that there is a paid product on that website as well, but you don't have to go anywhere near that. And if you do the first 5 steps, there's no, they don't take your IP address. They're not going to send you emails, none of that stuff.
Sounds really good. Thank you for the caveat regarding that. Appreciate it. Resources are always nice. And I think that safety comment, am I safe? And just pausing and the breath, I think that's very meaningful. And it adds a nice flavor to what you added at the end. I think we have time for one more question. This is a broad question, but I know it comes with good intentions. I'm just going to pose the question to you. How do you manage patients who are re-injured by physical activity? And so that could lead to some fear, that could lead to many different things, but do you have any thoughts regarding that area?
You know, I think the first thing that I think of is whether the person was re-injured or whether they cranked up an already cranky nervous system. I mean, it would be part of the thing. So let's assume that the person actually has re-injured their body. So now, of course, the person's not going to have the same confidence as before. And what we're probably, what I would do with that person is I would say, all right, so can you tell me the path you took? Can you tell me the plan you were on before and where the plan didn't go well? And what I'd really want to look at is, how fast the person was progressing their activity, if they were using any of these sort of movement guidelines that we've been talking about. I'd really want to watch how the person does it. I mean, it's amazing to me to see that a lot of times when people come, say, to a specialized physiotherapist because they can't figure out how to exercise, is that if the physiotherapist says to them, show me how you're doing your exercise, right? Because the person's already doing exercise that somebody gave them. Is that a lot of times what you'll actually see, so say it was like a shoulder problem, is you see the person doing their exercise and what they're doing with their shoulder is the right thing to do, but what they're doing with the rest of themselves is not. And you'll often see people sort of gritting their teeth and tensing their body up and holding their breath and turning away even while they do this exercise, which of course is going to bias the nociceptive system to be really, really cranky. And so often what we need to do is say to the person that, if you re-injured this, there's the possibility that the nervous system is even more sensitive than before. And so we probably need to go a little bit more slowly. So we're going to have to find a way to persist, but be patient and compassionate to ourselves, right? Because I think the other piece that we'd really need to get the person to understand is that recovery is not this direct, here's where I am, here's where I want to go, and I get better like this. Right? That's what we all assume. But to say to this person, what's happened to you is actually way more common than you think. Recovery is more of a get better and then sort of, You start to get better and you go back a bit, and then you get better and you go back a bit, and you get better and you go back a bit. One of my colleagues over in Europe says it's the shape of recovery is a little bit like a Toblerone bar on a hill, which usually gets people to think about a little bit, what the heck? So the idea is that it's more like this. It's more like this uphill roller coaster than anything else. And I'd really want to say to that person is that this is a difficult thing to do, to work with injured body and sensitized nervous system. What we need to do at this point is figure out how to make your nervous system less sensitive, and how to make the tissue of your body healthier as well. Which, by the way, I have to really point out is that it's a message that gets missed in a lot of the pain education. Is this idea is that it's almost like all we have to do is deal with a sensitized nervous system. So, and of course, that's not what the person in front of us wants to hear or believes. And we need to say, if this has happened, we've got to work on your body, but we've also got the sensitized nervous system we need to work on. So let's work on them both. And I think we'll engage people better, and we'll be able to give them a better understanding of what to do and a better approach to what to do if we work it on it like that, rather than just deciding the body doesn't matter anymore. It's only the nervous system we need to work on.
Thank you. Is it possible to sneak in one more question?
Sure, I got time.
Okay. Oh, thank you so much. Wonderful. So jumping back to listening to those alarms, we just had Joni who was asking, do you have any recommendations for patients who are trying new exercises, new activity, and may go slightly above their safety zone, so experience more pain following that and then are fearful to try again?
The first thing I'd ask, so if the scenario is that the person is pushed harder and now they're saying it's stayed provoked, right? It's not calmed down when I'm done. What I would do with that person right away is I would say, do you believe the consequences of what you just did outweighs the benefits of what you just did? Because you just did some things for your body, right? And you did some things for your mind, and you did some things for your spirit by doing that activity. And now you've got increased pain. It's like the person who has back pain and comes back to us and says, oh, I shouldn't have done it. My back's been getting better, but my friends were going out dancing, so I went out dancing with them the other night, and now my back's really sore. I mean, the very first question we need to ask that person is, do you believe that the benefits of what you did outweigh the consequences? Because this is not just a biomedical issue, this is a human issue. And if this person says, the benefits really outweigh the consequences, then we say, all right, so that's how we're going to move on. And we know now that much activity is more than your back, sort of more than you're ready to do for right now, and we need to slowly go up. But it's reframing it for the person with this idea of, just because the pain is worse, we healthcare people don't need to get really excited about that, because the pain probably got worse because the person cranked up the crankiness more so, right? Because that buffer, people probably did that more than actually did tissue damage. But when our response, when a person says the pain is worse, is, oh, well, we can't do that much activity, like right away, we just linked pain and tissue damage together again. And what we really need to do is get people to realize it's not as simple as that.
I think that was a really wonderful way to end, as it encapsulated everything you've spoken about from that biopsychosocial model. So thank you everyone for your engagement, who's been answering questions, Dr. Lilo, Dr. Smilich, thank you so much. And everyone who probably had questions, but nevertheless, we spurred on some good discussions, and thank you for your time, Neil, to speak with us today. And I know